The following is a presentation of Project Independence and WCWP. Project Independence is the Aging in Place initiative of the town of North Hempstead. We provide programs and services designed to assist and support the older town residents who wish to remain in their homes as they age. If we don't currently provide a service, we will try and connect you to that service. Call 311 or 869-6311 to get more information or receive services.
Welcome to Project Independence and You.
Welcome to Project Independence and You, Community Talk Radio on 88.1 FM and WCWP.org. I'm your host, Rebecca Miller, along with co-host Otto Lohse. How are you, Otto?
Good morning, Rebecca. Good morning.
Good morning. So this is our first show of 2022. So we're really, we've got a great show, of course, to begin with. We're going to start off our show by speaking with Dr. Boraiah. Dr. Boraiah, first of all, thank you so much for joining us on this snowy Friday, our first, I guess, big snowstorm of 2022 as well. It's good to see you on Zoom, so no one had to really go anywhere.
Right. Thank you. Thank you, Rebecca. Thanks for having me on the show. Good morning.
Good morning.
Yeah, great way to start the year with the snow. Yeah,
it's pretty, but it's better to kind of look at, I think, than to have to deal with in the morning. But Dr. Boraiah, you are an associate professor of orthopedics at Donald and Barbara Zucker Hofstra Northwell School of Medicine. So that's quite a mouthful. When in adult reconstructive and hip preservation orthopedic surgery program. You're also the director for the Adult Reconstructive Fellowship at Northwell Health. So there's a lot going on. And of course, most, if not all of our listeners are the older population. And I think, you know, all dealing with either for themselves issues related to, you know, all kinds of orthopedic issues, if not themselves, their spouses, that kind of a thing. So, you know, here we are in a snowy, icy day where, unfortunately, a lot of people could actually slip and fall in this. So we do hope that our seniors are staying home. There's no reason to go out on a day like today at all, especially if you have a nice, cozy house. So please stay home and avoid meeting Dr. Boraiah today. So what exactly is, just to get right into it, what exactly is hip replacement?
So, let me just, you went over my credentials. I work at, I'm the associate professor of orthopedic surgery at Hofstra. I mostly operate at a bunch of places, North Shore, LIJ, and also surgery centers. I specialize in hip replacements and knee replacement, basically joint reconstruction, and also hip preservation for athletes and people who have hip injuries. So I do a full paradigm of surgery from hip preservation to hip replacement, and also knee replacement surgery. We do a lot of robotics. So that's kind of the area of expertise. So yes, I understand the listener population is kind of targeted to older people, but the joint replacement is kind of the average age is getting younger and younger. So 55-year-olds, it's not uncommon to see. I do a lot of younger people too in their 30s and 40s, but to see a 55-year-old, a 60-year-old get a joint replacement is very common.
Right.
Like 15 years ago, that was not common. Now it's very common. So
why is that?
So I think the reason that is, you know, people want to do their thing, right? They want to live their life. So those days where say, oh, I'm 55, I'm 60 years old, it hurts. I'm going to sit at home. I can't do this stuff. Those days for most people are gone. Like, you know, you see a 60-year-old or a 55-year-old, 65-year-old person who says, oh, I've been skiing all my life. I want to go back and ski, and I want to do this. I want to do that. You know, they want to be active in their lifestyle. They want to go hiking. They want to play tennis. So my tennis coach is a patient of mine who I replaced both of his hips, and his knees are no good now, but I mean, I replaced both of his hips, and he's still coaching. and he gained his longevity. He could barely move before this. Now he's coaching. And so people want to be active in their lifestyle. So, and nobody wants to be in pain and limited by pain. They want to be active. They want to have an active lifestyle. I think that's the reason why people are, more inclined to getting, their bodies fixed in a sense, if you want to call it that way, so that they can move on.
So perhaps it's not really to associate maybe hip replacement with older people. Doesn't really have to happen. I mean, it seems like we make sure we do maintenance on our cars so they last a really long time.
Right.
But yet if we feel something in our hip, we just kind of say, oh, well, it's age, that's normal, instead of saying, hey, let's see if we can fix it so that we're not uncomfortable and we can continue living the lives that we want to lead.
Yeah, absolutely. I mean, like the way I tell patients, right? If you're moving, everything in your body stays healthy. Your heart stays healthy, your blood pressure, your diabetes, everything is in control. Now, if you develop a little bit of problem in the hips and the joints, especially walking, load-bearing lower extremity joints, and then if you become immobile or, your overall health goes down. So this is just not the knee pain that affects the knee or the hip pain that affects the hip. It affects your overall well-being. If a patient or a person has bad joints when he's at 50 and he didn't do anything for 15 years, you can see his health will overall decline. He'll not be the same person. His blood pressure will be high. He's going to have medical issues because he's not mobile. So I think, yes, it is in a way to get the pain away and to restore your active lifestyle, but also to give the person's overall health back. Because if you, like I tell patients before I do surgery, right? Some of them come and say they want surgery and they're so far gone, they're deconditioned, they're in a wheelchair. And I tell them, like, if I give you a new car, if you're going to put the car in the parking lot, what's the point of giving you a new car? I want to make sure that you use the car. So you don't want to get to that stage where, you get a new joint, but you can't do too much with it. So it's not an operation just to say, okay, it's, I'm at the end, I can't do anymore, I'm just going to get a joint replacement. I don't think that's the way to look at it. So that's why more people are getting aware about this. And of course, it has to be a strongly indicated or a surgery that is actually correctly indicated. You don't want to take a young patient who has a little bit of arthritis and do the surgery. They're not going to be happy. So for correctly indicated patients, I think it's life-changing.
Well, I'm of the age bracket that I know a lot of people who've gone through all of these things, hips,
Right.
knees, etc. And one of the things I notice, and I completely agree with you, that people who don't take care of it, their mobility goes down, their lifestyle goes down, and it's a bad picture. But another thing I notice is that it's like a ripple effect. If your knees hurt or your hip hurts, all of a sudden your back hurts and
Right.
your thigh hurts and everything else hurts, and you're in pain. Is that a common occurrence, where other things start to break down, if you will?
Right. So what happens typically is, say if your knee hurts or hip hurts, right? So normal reaction of the body when you have these joints, aches and pains, the body bends over, the body flexes. So if your knee has long-standing arthritis, the knee will fully not straighten or bend. So what happens is your spine accommodates to it. So if you have long-standing issues, you bend over and you accommodate that with the spine, and that is not great, because if you fix the hip or knee 5 years down the line, you can make them straight, but the back has taken the toll because you've been walking on it bent over, and it affects the back. So a lot of people I see who have back pain, who have bad hips, when I fix their hips, they feel better in the back because they walk up straighter. So in a way, if you fix the alignment, everything works well. But of course, these are within reason. But most of the time, yes, you have to make sure that they're walking straight and everything is in line so that it doesn't take a toll on other parts of the body, like the back.
My mother had both hips and both knees replaced Luckily, I have not inherited her joints. But I know some people, like my mother was a pretty hardy stock, and she was able to get through this whole process without a lot of pain, if you will. And yet I know other people who are much more, they have less tolerance for pain, let's put it that way. And
Right.
they go through a much, much more difficult time.
True. Absolutely.
Can you
So,
predict in advance what's going to happen?
so that's a bit, I'll tell you, I'll answer that question as candidly as I can. So for correctly indicated surgery for a patient who's in need, you do the surgery right with all good intentions, and I do the good work, the patient does his part. Most patients are fine after a few weeks. Now, we do these surgeries ambulatory, like, do it in the morning, you go home in the afternoon. This is not for just younger patients who are 70 years plus. We still do them outpatient setting. You do them in the morning, you go home in the afternoon. And they do just fine because we have gotten the science down to control the pain perfectly within reason, that it can be managed with just tablets. Now, another thing with that is if I take two patients and do the same exact surgery and give them the same exact pain medicine, the two people will have different perception and reaction to pain. That is something you can't predict. Now, we get a sense of which one is a complainer or which one is going to be a trooper, but that does not really translate to who's going to have more pain, who's going to have no pain. It's something that eludes me. Maybe other people, smart people might know, but I think you can't say that. But after a few days, I think things will even out and they'll do fine. But like, if you ask me the question of, am I going to be in pain? My answer is yes, you're going to be in pain for the first few days.
Well, I know somebody, actually, I'll be open and candid about it. My wife, who just recently went through knee replacement surgery, and she still has a lot of pain. And she happens to be in the wrong side of the camp when it comes to pain tolerance. So the reality, I guess, is that some people I know who, after a couple of weeks, they were up and hopping around. And then there are other people who can go 2 months, 4 months, where they can maybe move around, but they have a lot of pain. And I wonder if it would, like prior to getting the surgery, if a discussion were to take place that says, like everybody asks you, I'm sure, like you did, you ask the doctor questions about, well, how long will this take? And you'll say, well, typically it takes 2 weeks, 4 weeks, whatever. But like on your behalf, you really don't know what that person is going to be like when it comes to their mindset, their PT desires, or lack thereof.
Right.
Like, do you have like maybe?
So this is what I tell patients typically. So like you said, every patient is absolutely different. Let's make this clear in a sense that we are only talking about the acute part after surgery, meaning only the first few weeks. Because after a couple of months, the goal is to be pain-free and functioning at a high level. So that is a different part of the spectrum that will come. Sooner or later, you will get there. But the initial part of the surgery, this is what typically I say, you'll be walking straight away with a walker or a cane. And in 6 weeks, they'll usually be about 80% better. That's typically what I say. So now some patients maybe 3 weeks, some patients may take 10 weeks. So average in 6 weeks, I say patients that you will be 80% better, and the rest will come slowly over the course of time.
Which is difficult to predict what that course of time is, right?
Right.
Maybe that's why it's good to kind of get these procedures done when you are a little bit younger, because I would assume that recovery is a little easier when you're 55 than if you do it when 80. So it's really, I guess, best to, pay attention to these things that we kind of put off and say, oh, it's just age or it's arthritis, because perhaps it's not, and you could get this procedure.
Right.
A question I have too is, I'm sure a lot of people ask this, How long do these hip replacements last? I mean, I assume as technology advances that, a hip replacement, does it generally last the rest of your life? If you're in your 50s, that could be 50 more years or 40 more years,
Right. So I think so. The literature on that, this is this, the new bearings, right? We've been putting on since probably about early 2001 or 2002. So these are highly cross-linked bearings. These are high density polyethylene bearings. So they have excellent track record. So they don't wear out. Wear out is extremely low. It's about 0.01 millimeters or something really, really small. So now this is lab data, right? This is the result from the labs. So we have patient data for the last 20 years because these are new bearings. We have not been doing the same bearings for the last 50 years because this is new. So I tell patients, we have patient data to support it for 20 years and patients are fine. But in the lab results, it shows that this lasts much longer. So if I put a joint in a patient who is 50 and with the high density bearing, it can last. I told the patient, I don't really expect to revise this because the bearing is going to wear out. But I can't promise you because we don't have patient data because this is only 18 years old. But the lab results show that the wear rate is extremely low. But the older plastics, which we were putting in 70s and 80s when I was not operating, or even like 90s, the bearings were not as good as the current bearings. And the press then is like, oh, your joint's going to last 20 years. So that was the kind of the thought, like, okay, your joint replacement is going to last 20 years. It's kind of true for those implants. For the new implants, it's not true. But you also have to be mindful that 10 years a 40-year-old puts on versus the 10-year-old, the 10 years that a 60-year-old puts on is totally different.
Right.
So there's a lot of
wear
things
and
that
tear.
wear and absolutely, it's going to be exponentially high what a 40-year-old does in the 10 years compared to what a 70-year-old does in 10 years. So it's really not the same because he's going to be jumping and kicking. So the new bearings have excellent track record, and I don't really expect to wear out quickly. Of course, it has to be mechanically right, aligned. If your car is malaligned, if your wheel alignment is off, it's going to wear off. So if
Dr. Boraiah, I'm sorry, we have to take a quick break, but we'll get right back to it when we return. We're speaking with Dr. Boraiah, talking about joint replacement. You've been listening to Project Independence in You on WCWP.org, 88.1 FM, and we'll be right back.
So I get this call from my grandma, and she's like,
"What's a podcast and how much does it cost?"
So I tell her, podcasts are like radio shows, but you can download them on any device and listen to them anywhere at any time, and they're free. And then she says,
"I see, but where can you find good ones?"
And I'm like, go to wcwp.org/podcast and check out the lineup of original shows, or download any podcast app on your phone or tablet and search for LIU Studios. And she's all like,
"Oh, that sounds easy."
And then she asked me what an app is.
LIU Studios podcasts, available on any podcast app. You know, those little button things on your phone screen. Just ask your grandkids.
Oh, welcome back to Project Independence in You on Community Talk Radio, 88.1 FM and WCWP.org. I'm your host, Rebecca Miller, along with co-host Otto Lohse, and of course, our radio show producer extraordinaire, Christina Liu. We'll be chatting with Christina later and talk of the town. But right now, we're going to get right back into it. We were talking with Dr. Boraiah, learning all about joint replacements and all kinds of procedures and ages and how long they last. So this is just, a lot of really good information. And, again, I thought it was kind of ironic to have you on the show today when we've got a lot of ice and snow out there. And we're just hoping that everybody is taking their time and just looking around, making sure you don't have any ice patches. And more importantly, maybe just even staying in today.
You know what I was thinking might be not a bad idea is if anybody, like we have 20, 30 people listening usually, but if any of them have knee or hip problems that they're thinking about or they have, what would be the process? what would I do if I have a knee that hurts? And now I know I should go to a doctor. I should go to an orthopedic doctor. And what would happen? What would be the, what do I look forward to going to before I get to where a replacement is the equation? Like, what other options do I have to get there?
So if your knee starts to hurt or hip starts to hurt, first wait, make sure it is really hurting, because if it hurts for 2 days, don't rush into saying, oh, I want to see a doctor, because just wait it out in your house, stretch it out, do exercises. Unless you fall or hurt yourself, no need to rush and see a doctor, unless in your mind, there's something wrong and it's been going on for some time. So if it still hurts over the course of time, if you've done your basic stuff like little stretching, taking medication, taking Advil, and if it still hurts, and then you say, okay, is it really hurting enough for me to see an orthopedic surgeon, or can I see my primary doctor? Now, sometimes the primary doctors have good orthopedic knowledge and they can get x-ray and say, okay, this can just be treated with some physical therapy. Or they say, okay, you need to see an orthopedic surgeon. Or if the patient decides, no, I'm going to skip the primary doctor, I'm going to see the orthopedic surgeon straight, that's perfectly reasonable too. So when the patients decide to come and see an orthopedic surgeon, so we look at the overall picture. So I'm going to say, how is this patient functioning? How long is this pain going on? So when we talk about surgery, it is the last treatment option we have. And before that, there's a multitude of treatment options before we do anything surgical. So the way my practice works is most of the patients who come to me have tried everything, and they already know what they're going to do. They want to say, they actually tell me, I want this, then at this time at this hospital. I say, okay. But most patients are not like that. So most patients, when they come with pain, we get x-rays to see what actually is going on. And now the patients may have pain and the x-rays may be perfectly normal. In those circumstances, if we think there is something torn or something, we can get an MRI. So sometimes when the arthritis is full blown, MRI is not necessary. So MRI is really a tool for diagnosis when information and the clinical picture doesn't meet. Sometimes the patient says, oh, I need an MRI. And the MRI is not going to treat the patient. The MRI is a tool that will give us more information that if we're going to act on it. You don't want to do a test just to look at it, just to say, oh, okay, you have this. Okay, so now what? What are you going to do? So the treatment options from our perspective before to get to the surgery is a lot of treatment options. You have to at least try conservative treatment for about a year. You have to have tried everything. We do physical therapy, we do injections, we do activity modification, we do home exercise programs. If the arthritis is mild and the patient is busy, we say, okay, you don't have to go to physical therapy. You can do home exercises. You can go to the gym. You can do certain exercise. And, if it's a little bit more advanced, then we can send the patient to physical therapy so that they get a structured education program. Sometimes we know that people get really busy, and I get that sense when people get busy and they don't take care of themselves. And I say, go do exercise. They say, no, you know what? I'm just going to do it at home. As a physician, it's my responsibility to make sure that this patient actually takes care of himself. So I push them to say, actually, you know what? You should make time to go to physical therapy because it will get you going and it will make you spend the time you need to do to take care of yourself. So the patients sometimes overlook that, right? They say, okay, you know what? I'm too busy. I can't do this. But they don't really understand it's actually very important. My role is to say, you actually have to do it. It is helpful. And patients say, really, I want to do this. Is it really going to help? And the answer is yes, because it will get you going. It will get your joints and muscles strong and stretched out. So there's a multitude of treatment options, including home exercise, physical therapy, and then we can try injections, which I can talk about later, before we do anything surgical, anything thinking of close to doing any kind of surgery.
So even though your title, like people say, orthopedic surgeon, that doesn't mean when you walk into your door, you're automatically going to be getting surgery.
Absolutely not. Absolutely not.
which is, I think, important for people to understand that
Right.
the mission is to try to fix things before you get to that point. So a lot of people are afraid to go to the doctor because they figure they're going to have to go for surgery. Maybe that's not the case.
Absolutely not the case. Absolutely not the case. So we are here to help people and get them back on their track and lead their lifestyle. Now, surgery is an option. There are other options too. Now, the orthopedic surgeon is a good person to give that opinion because in our experience, we know what condition needs what treatment. Not every physician can really say. They might read the MRI report and say, oh, you have this, but they don't really know how to quantify the problem. So you don't need the surgeon to always say to go if you need surgery. A surgeon can give you advice and treatment plans even if you don't need surgery. Sometimes it takes me longer to convince patients that they don't need surgery than to tell patients they need surgery.
That's unbelievable. Because
Right.
I'm thinking of people that it's so, I have, my friends' moms and even my own that definitely would benefit from a knee. And my friend's mother needs both hips, but it's amazing how they will allow their lives to become so limited.
Right.
But they're so afraid to have the procedure. And I know a lot of the reason is, going under anesthesia as an older person, and also hearing horror stories from their friends. Now, a lot of their friends that get the surgery are talking to them daily, how horrible it is, how much pain there is. But yet a year later, they're, like you're saying, Dr. Boraiah, they're playing tennis again. They're going on their favorite trails. They're doing those kinds of things. So it's like there should be a code of silence for the first 3 months after your friend has a procedure. And then, so that because it's basically, it's kind of stopping people from doing it. I'm curious how, like you're saying, how you have to convince people that they don't need surgery, but I'm sure you have plenty, especially older people that are, they figure, listen, I'm 82 years old. Why am I going to get my hip done? Because you have longer to live and you want to live the best life you can. How do you, is there, I'm sure you come up to this all the time.
Right. So if I see patients who have bad hips, both of them, right? If I see them at 75, they're reluctant, they've suffered for the last 5 years. And I say, I fix one hip. They're really kind of reluctant. I say, you really need it. And then they convince and we do the surgery on one side. 2 weeks they come, they're asking for the other side. So
Alright.
They don't really know what good is because they have forgotten about it. And in 2 weeks, they're going to say, when are we going to do the other side? So there are that group of patients more often than I think. That group of patient population is absolutely there. They're reluctant. And also bad press gets more press,
Right.
like anything else in life.
Yes.
So if somebody goes, like people who write online comments, right, online stuff, most of the
Right.
time, happy people don't go online, take their time and say, oh my God, I had it. People who are unhappy for whatever reason, they are the people who take the effort. So the bad press gets more of a press in a sense. So
Right.
An educated consumer or a patient should really do their research to talk to people to see who is actually telling the truth, who they have to do their research. As a physician, my role is to tell you what will help you and guide you. Now, if I can't say patient that you need surgery 100%, I say your joint is bad, it will help you and you help your lifestyle. And the patient has to make up their mind and buy into it. Like sometimes I have patients and the family come and the family is keen on getting the surgery for their parents and the patient is kind of reluctant. And at that time I say, listen, the surgery I'm doing is not on your parent, not on you. Unless they buy in, I'm not going to do this. So at that point, because the patient has to buy in, they want to get better. If the patient doesn't want to get better, there's no point that we can make them better. For that, it's my job as a physician to educate them. The education part is where we come in. The decision part is a combined decision part. Education part is mine. Like, am I really helping you? This is the question I ask myself. Can I help this patient? Is this life going to be better? And if the answer to that question in my mind, in my heart, is truly yes, and then I'll tell that patient. And then the patient has to do his research and think and do what is right for the patient.
Well, I hear talk about bad press, good press. The story goes that the hip is much easier than the knee. Everybody who's been through both of those will say the hip is much easier than the knee.
Right.
In your
So the
opinion,
hip
is that true?
Right. Yeah, the technically hip replacement is I do a lot of anterior hips, meaning it's the front of the hip surgery. You don't cut any muscle. It's technically a more challenging operation. From the patient's perspective, absolutely. Hip replacement is much quicker to recover and less painful as an operation compared to the knee. It's just the nature of the operation.
Right. Well, and then the phrase I hear is bone on bone. Once you get to the bone on bone category, particularly with the knee, your options are very limited. Is that a fact also?
It's also a fact, but I see a lot of people sometimes who are bone on bone, who are functioning, who are 85. I see patients who are 85, who are not using a cane, are perfectly functioning. They play golf. For those patients to really say, oh, you need to get surgery, it's kind of not right, because they're functioning and they're not taking any pain meds and they're doing everything in their life. Even though they're bone on bone, sometimes they adapt and limit their range of motion, and their pain perception is different. So there are a group of people, if they're functioning at a high level, even if they're bone on bone, like you said, it's an advanced stage of arthritis, meaning the cartilage, the cushion in between both the bones are gone and the bone is touching the bone. That is an advanced stage of arthritis. But we don't treat the X-ray, the picture all the time. We treat the patient. So if the patient is highly functioning and doing everything, I say, okay, let's wait it out. See what happens, do exercises. And then if it bothers you, come back in 6 months, we'll reassess.
You use those words, pain reception. That to me is like a magic something or other. Like everybody has a different pain reception, as you point out. And it really comes across when, particularly knee surgery, I've witnessed now a half a dozen people go through it. One had both knees replaced at the same time, and they were like tap dancing after a few weeks and with very little pain. So I think the thing that's probably not an exact science is pain management and pain reception. You're thinking on that,
Yeah, absolutely. I mean, like I said, that is something that eludes us. Like, I can't predict which one is going to have no pain at all and which one is going to need more pain meds, and I'm going to get the phone call, so I need more pain tablets. That's something I can't predict. We have a sense, but like different people are different. But for most part, when you have bad arthritis and your leg gets deformed, like if you say your leg, if you have a slightly bowed leg when you're born, most people are, 80% of the people are. And when you develop more arthritis, you lose more bone and the leg gets more deformed meaning it gets more bent. So when you start to develop deformity, meaning like your car, I'm just going to give an example of the car. If your car starts to wear and if your wheels lose alignment, the tire is going to wear out quicker. It's off alignment. So one thing makes the other thing worse. So if you're starting to wear your joint and it gets more bent, that actually gets worse over the course of time. And then the reconstruction becomes harder. So when there is deformity involved, you have to really think, okay, am I just convincing myself that I'm not in pain, I don't need help, versus I need help. So that sometimes when you have a patient whose leg is bent 30 degrees and they're like walking bowed leg on the side of the leg or on the inside of the leg, you tell them it's going to affect every part of your body. So you have to really consider what to do, what is right for you.
Well, this is hopping around a little bit here, but I read some of the material you sent, and when people go for hip replacement, I read this anterior versus posterior method of doing the surgery. And when I read it, I'm thinking to myself, why would anybody do posterior surgery? Is this a question people should ask their doctor, or is there a reason to do this posterior? Maybe just elaborate a little bit on that.
Right. So I do all primaries anterior. So there may be some bias in what I say, but there's a reason. So the listeners should understand whatever I say may be partially biased because I do everything from the front. That doesn't mean that I don't know how to do posterior. I do posterior for complex cases. My residency training, all my approach and training was posterior approach. My fellowship, I did both anterior and posterior approach. And I also did some specialized training in Switzerland for a few months to do more anterior fellowship, to do more anterior training. So I have seen both approaches. I do both approaches, and I pick anterior approach. So yes, I'm biased because I do anterior approach, but also there's a reason why I think anterior is better. So when the surgery.
Okay. We're going to just take a quick break. Dr. Boraiah, you saw that little note and you appreciate that. We will be back with Dr. Boraiah talking about joint replacement. You're listening to Project Independence in You on 88.1 WCWP.org, and we will be right back.
Take WCWP with you wherever you go with the WCWP app. Listen live 24/7 to all of our streams, all from one app. Plus, call the studios directly from the app and visit our social media. Download the app through the iOS App Store on Apple devices or the Google Play Store on Android by searching WCWP Radio, or visit WCWP.org for links. The WCWP app, available now on iOS and Android devices.
Welcome back to Project Independence in You on Community Talk Radio, 88.1 FM and WCWP.org. I'm your host, Rebecca Miller, along with co-host Otto Lohse and our radio show producer, Christina Liu. We've been talking with Dr. Boraiah, getting a lot of really interesting information, and I like it so much that it's coming from your perspective, and you're so honest about outcomes and, even telling people they don't need surgery. So it's great to have your perspective on that. And I know over the break, we were talking a little bit about what's kind of interesting, what you would like to maybe talk a little bit about, and you kind of brought up robotics. So what's happening with robotics and orthopedic surgery, and what kind of experiences have you had?
So I have a 5-year-old son. I take him to Stop and Shop, and there's a little robot that comes in the aisle and he gets scared. So that is actually what robotic surgery is. No, I'm just kidding. So robotic surgery means basically what robots basically are is a glorified math equations. So you give the computer the information of where the bone is, where the parts are, and then and you make a plan on the computer and say, okay, I want this implant or whatever put in this degree, this angle, and the robot is just a tool that helps the surgeon do the surgery. When I tell people, mention about robotics, they say, oh my God, are you going to be doing the surgery? I said, no, I'm in the beach doing the surgery. No, I wish I could do that, but we are not. I'm there doing the surgery. The robot just helps me guide the surgery. The robot, the ones we typically use, is like an 800-pound box that sits in the operating room, and it has an arm that is controlled by me, but the arm also has a little bit of its mind. It won't let me cut off access or something. So basically, a robot is a tool to make the surgery. You still need a surgeon. You still need the decision and judgment of the surgeon. It's like I tell people, right? You need a coach and a team to execute the plan. So both are important. Without, coach can give a solid plan. Like, Bill Belichick can give a great plan. If Tom Brady is not there to execute it, it's not going to happen. So you need the plan and the robot is there to help you execute the plan. That's basically what it is. If you give garbage information to the robot, it's going to give garbage information out. So robot is a tool, the new tool in the current joint replacement world that helps us make the surgery precise. It's not like it's going to do the surgery on its own. We still need the people to do the surgery. It's just another tool.
Right. It's like driving a car. The surgeon drives the car. The car doesn't know where you're going or what to do. You're controlling it. So you're kind of controlling all its mechanisms, I guess.
Right. I think the future, if you want to talk about, maybe this may not be pertinent to this discussion, is there's artificial intelligence is coming everywhere.
Right.
And the computer can give you information, say, you say this is what the problem is, and then the computer can give you information and recommend the information, and you just say, yes, we're not there yet. It might happen one day, but as of now, the surgeon makes a decision. But artificial intelligence is going to kick in, and like everything like in world, machine learning and artificial intelligence is less prone to error. Humans, now if I tell an old surgeon, right, a robot is better, not better, a robot is precise, most surgeons won't take that like lightly. They get upset. Oh, you don't, but the truth of the matter is a machine with good information in is more precise than a man. That's the reason why airline industry does not rely on humans to fly thousands of planes. The technology will always help you, but you have to be wise enough to see where it helps you and how to use the technology.
Right.
The technology is right.
I'm sorry. A number of years back, not that many, but I had a little run-in with prostate problem, and the urologist, who was also a surgeon, actually showed me a video of robotic prostate cancer surgery, and there the robot actually was doing a little bit of the work along with it. So it's really pretty unbelievable, and I can only imagine where all this technology is going to be 10, 20 years from now.
Right. Right. I think that, urology robot is slightly different than the orthopedic robot. But right, urology robot, the Da Vinci robot has revolutionized urology prostate surgery. Orthopedic robot we typically use, every company has their robot. Stryker has the Mako robot. Zimmer has the Rosa robot. I happen to use mostly Stryker robot. Yeah, but the technology is changing. But the problem with medical devices and medical stuff is like iPhone, right? Like 20 years ago, 15 years ago, there was no iPhone. iPhone came, and then the iPhone 2, iPhone 5, iPhone 13. But in the medical industry, the advancements are very small. You can't say, oops, something happened.
Right.
And there's no oops. Like, Apple comes up with a product and there's a glitch and they say, oh, let's give a new software. You can't do that in medicine. So the advancement of technology is very slow, and still problems happen, like metal on metal hips that was recalled. So anytime you adapt a new technology, I'm very good proponent of the technology. But having said that, I don't use anything that is fresh to market because I don't know. It has to be tried and tested to some degree. But also you don't want to be doing some 50-year-old surgery. So it's a fine balance to say what works versus jumping on the bandwagon of the new technology. Now you buy some technology, it doesn't work, you can put it in the garbage. But if in a human, you can't do that.
You use the word human. To me, there's parts to this equation. One of them is the technical part. How do you function? How do you do it? And I think a very important part of it is the human relationship with the doctor himself. I believe that your mindset has to be, as a patient, has to be positive, has to be able to have an open communication with the doctor, and frankly, to be blunt about it, not to be just lectured by the doctor, but for you to have input with the doctor and communicate in a language that can be understood by both sides. And
Right.
I believe, without knowing you beyond this, that you would fit into that category. You have to be able to talk to the doctor. A lot of people are afraid to talk to their doctor, and I tell them, well, why go? If that were the case, then it's like the doctor treating a donkey. The donkey
Absolutely.
can't talk. So you got to
Right,
talk.
absolutely.
Tell the doctor what's going on.
Yeah, I mean, the relationship between the patient doctor is really essential. It's not like you're buying a product, you're giving your part of your body to someone's hand. So the trust is really important. Even from the physician's point of view, you have to make sure that the patient is comfortable and you're doing your best. And every time I go to perform something, I, in my mind, know honestly that I'm going to do what is best. And what is best, I can do what is best from within my capacity, right? I can't perform to somebody else's capacity, but I perform what is best in my capacity. And the patient sometimes, if they like you, if they're also a little bit not 100% satisfied with the surgery, they're okay. But there are patients who are absolutely fine, change life night and day, but for some reason, if they don't like you, they still are not really, happy. So understanding the doctor and the physician and the patient, they have to be really on the same page. And the doctor has to have faith. I mean, the patient has to have faith in the doctor. It's a hard thing, like anything in life. You have to trust the person. Like I tell patients, they ask me, like, why should I pick you versus why should I do the other surgeon? Like I said, listen, you're perfectly welcome to go to the other doctor. Any good surgeon can do the same job. I'm not saying he's better, I'm better. Whoever you're comfortable with and whoever you think is going to do honest work on you, you just should go with them. And if you think the other person is, absolutely do it. Because if you don't have enough faith in me that I'm going to do the perform, it's really not right for them or me to do this. So I think doctor-patient, physician-patient relationship in the recent days are changing because patients' expectations are different. The social media play comes into play. So that's the sad part of the equation, right? Like any other industry, you can say, nah, I can't, I can't treat this. As a physician, I can't say that. I have to take care of the problem. Anybody else, they say, no, find somebody else. So from that point of view, medical profession to me still holds that value because we are ethically and responsible for the people and the patients. So doctor-physician-patient relationship is evolving with social media and time. But sadly, I think it's going towards bad way in a sense that patients have less trust and physicians also. There's a wide variety of it. But I think honestly, at the end of the day, a physician should be honest and the patient should be honest. And I think that's when you get the best outcomes.
Perfect segue to my next question is, how do people get in touch with you, Dr. Boraiah, if they want to consult with you?
So you can Google my name and my office number is on there. Or if you're not internet savvy, my phone number is 516-773-7500. That's the main Northwell orthopedic service line number. And They can call that and then they can ask for me, or if you can be directed. But yeah, so it's the Northwell Physician Concierge service line puts you in touch with me. So yeah, that's not hard part. Or you can, most of these appointments sometimes can be requested online as well. Mm-hmm. But yeah, it's fairly easy process.
There's two things that come to mind. One, and I have a couple of doctors that I know. Unfortunately, sometimes doctors are on the clock. You get 15 minutes to talk to somebody, and that's what minimizes the ability to establish a relationship because you got to get right to the point, and then your 15 minutes is up. And you really have less time with the doctor because there are a lot of other people who get involved, with checking this, checking that, and the whole bit. So you're only with the doctor for a short time. That's not the doctor's fault. That happens to be the way the world is right now. Part
True.
one. Part two, to me, a very important part of this whole thing is your faith that you're going to be able to follow up with this doctor if you have a problem. Like with a surgeon, again, I'm not knocking, there's lots of great surgeons, but sometimes a surgeon can look at it and say, okay, mechanically, everything went hunky-dory and I'm finished. And good doctors don't feel that way, in my opinion. They will understand that there's pain to be managed and I have other things that have to be taken care of. So to me, when people look for a doctor, they should be looking for somebody who they know they can also work with after the surgery, you know.
Right. So yeah, I mean, I'll ask that question. So, right, like it goes back to the point of physician-patient relationship, because that is really important. Because if there is a little bit of there's no sync there, it's not gonna be a happy relationship. It's not gonna be a happy marriage. So right, I mean, in this day and age, the time we give the patients is getting shorter and shorter because there's a variety of reasons. You know, most of it is driven by the insurance and the payers and this and that. But most of the time, when the physicians, as an honest, good practitioner, they need to get the information from the patient regarding their problem in a full, thorough manner. Now, be it from the physician assistant, medical assistant, x-rays, and other sources that the information, before I go to see my patients, I have seen all the images, MRIs, in my office before I enter the room. Sometimes the patients may think that, oh, I haven't seen your x-rays. I actually seen everything, all the images. But right, so there's a little bit of a sad part that the time is getting shorter and shorter with the physician-patient time, face-to-face time. But the good part is technology helps us to get there before we make a valid decision. And then the second point is, right, if the patient says everything, and the doctor says everything is great, x-rays look great, and the patient says you're in pain, patient is in pain. It doesn't matter what the x-ray shows. We have to address the pain. Now, you might not have a great solution to why this is happening, but as a physician, it's my duty to look into and try solution to say, what is the problem? You can't just wash your hands, bury your head in the sand and say, oh, it looks great, do something. At least for me, if the patient says it's pain, I look into in detail, like, why is this happening? And that's a part of being a physician. And a clinician is to help the patient, not just do the job and move on. That's not the point. That at least in my practice, and we are here to help them. Not say.
Well, on your behalf, there's the same story with the pain reception thing. You give one person oxycodone and the other one Tylenol and whatever, and it doesn't work, but it works on somebody else. So, on your behalf, I don't think that's an exact science either. That's
not an exact science either. So that's where the relationship comes into play. Now you tell the patient, honestly, we are doing everything we can. This is the process. It's going to take time. The patient trusts you and the physician is honest, the relationship will end well. Now, if the physician is brushing the patient off and the patient thinks that, at least perceives that he's being brushed off, then it's not going to work well. So that is the onus is on the physician to take time and explain to them that we are doing everything we can.
Right.
Agree.
Well, actually, that's we've come to the end of this segment too, Dr. Boraiah. We want to thank you so much for giving us a full hour of your time and all this really great information. It was extremely helpful.
Thank you for having me.
Well, we definitely would have you back because there's just so much more to talk to you about, and your honesty has been great. Our next segment is going to be Talk of the Town with Christina Liu. You're listening to Project Independence in You on 88.1 FM and WCWP.org.